Welcome to the RadOnc Smart Review GYN Cancer Series.
We're diving deep again, this time into cervix cancer, specifically looking at concurrent chemoradiation for locally advanced disease.
Right, and this is really foundational stuff, the kind of evidence you absolutely need to know cold, whether you're prepping for boards or just starting your GYN rotation.
Exactly. We're talking about the data that underpins really a massive shift in how we treat these patients. It was a true paradigm change in radiation oncology.
Yeah, you could almost call it a revolution, couldn't you? It dramatically boosted survival rates.
It really did. So our goal today is pretty straightforward. Break down the key trials, connect them to how you make decisions clinically, and make sure this knowledge sticks.
Let's ground this. We need a case.
That's a good idea. Let's talk about, let's call her Mrs. Davis, a pretty typical scenario.
Okay, Mrs. Davis, tell us about her.
So Mrs. Davis is 55. She's just been diagnosed with cervical squamous cell carcinoma.
And clinically, what did the exam show?
It's a bulky tumor, measuring about 5 centimeters. And importantly, the exam and imaging show it extending into her left parametrium.
Okay, left parametrium involved. But
Crucially, it does not reach the pelvic sidewall. That's a key distinction for staging.
Right. And her workup included a PET CT.
Yes. Standard staging PET CT showed avid uptake in the tumor itself, as you'd expect, and it also lit up several pelvic lymph nodes.
Pelvic nodes positive. Any sign is spread further up. Periortics, distant ments.
Fortunately, no. The PET was clear in the periortic region and showed no distant disease.
Okay, so putting that all together,
Yeah.
using the current FIGO 2018 staging, where does that land, Mrs. Davis?
That puts her squarely at FIGO stage 3C1.
Let's break that down, the 3 part.
Well, stage 3 means it involves the lower third of the vagina, or extends to the pelvic wall, or causes hydronephrosis, or involves pelvic end or periortic nodes. In her case, the parametrial involvement not reaching the sidewall would typically be stage 2B based on the old system purely on physical exam.
Ah, but the nodes change things under FIGO 2018.
Exactly. The C component incorporates nodal status formally into the stage. C1 means pelvic node metastases only. If she had periortic nodes, it would be C2.
Got it. And the R?
The R just signifies that the nodal status was determined radiologically in this case by the PET scan rather than pathologically, from surgery.
So stage 3C1R. That's the definition of locally advanced node-positive disease.
Precisely.
Which brings us to the core question. What's the definitive curative treatment for her?
Right.
And where's the level 1 evidence that says we absolutely must add chemotherapy to her radiation?
Right. To really appreciate why ChemoRT is standard, you almost have to look back at what we did before.
Before, say, 1999.
Yeah, before the late 90s. The standard for someone like Mrs. Davis was radiation therapy alone, external beam to the pelvis, followed by brachytherapy.
And the results were suboptimal.
Suboptimal is putting it mildly. The rates of both pelvic recurrence and distant failure were just unacceptably high. We weren't curing enough patients.
And there was that older strategy, EFRT, extended field radiation therapy.
Right. For patients considered higher risk, maybe extensive parametrial disease, bulky tumors, node involvement, some centers tried EFRT. The idea was to prophylactically treat the periortic nodes up to the diaphragm.
Tried to catch a microscopic spread before it became obvious.
Exactly. But the problem was toxicity. Treating that much bowel, kidneys, it led to really significant long-term side effects, especially GI toxicity.
And did it actually improve survival enough to justify that?
Not really, not dramatically. The survival gains just didn't outweigh the severe toxicity for most patients. Radiation alone, even extended field, just couldn't adequately address the systemic component of the disease once nodes were involved.
Okay, so that sets the stage perfectly. Then came 1999.
1999. The NCI, the National Cancer Institute, issues this clinical alert. It wasn't a suggestion. It was basically a directive based on multiple randomized trials.
And the message was?
The message was clear. Cisplatin-based concurrent chemoradiation is the new standard of care for locally advanced cervical cancer, period. It was an immediate shift in practice.
It's driven by level 1 evidence. Let's dig into those trials. Which ones were key?
Okay, one of the absolute cornerstones was GOG 123, Gynecologic Oncology Group Trial 123.
And what was unique about GOG 123?
It's critical because it wasn't looking at stage 3 or 4 patients initially. It focused on women with relatively early stage disease, stage 1B, but bulky disease.
Defined.
Tumors 4 centimeters or larger, so still confined to the cervix, technically, but big and aggressive. The question was, does adding chemo help even then?
Interesting. How was the trial designed? What were the arms?
Well, it reflected the thinking at the time, so it had a surgical endpoint. Arm 1 got standard radiation therapy, external beam plus brachy, followed by a planned adjuvant hysterectomy.
Okay, RT, then surgery.
Arm 2 got the same radiation, but with concurrent weekly cisplatin, 40 milligrams per meter squared, also followed by the planned adjuvant hysterectomy.
So RT plus surgery versus chemo-RT plus surgery?
Yes.
And the results?
The results were striking. The chemo-RT arm, the one with cisplatin, had significantly better overall survival.
Wow. Even in bulky stage 1B.
Even then. And they also saw much higher rates of pathologic complete response, meaning no residual cancer found at the time of that hysterectomy, and better disease-free survival. It proved the principle. Adding concurrent platinum helps, even for bulky but still cervix-confined tumors.
That's a key takeaway. Now, let's address that hysterectomy part. It was in the trial design, but we don't do planned adjuvant hysterectomies after definitive chemo-RT today, right? Why not? This feels like a classic boards question.
Absolutely. It's a crucial point for modern practice. Back then, the hysterectomy was sort of a belt and suspenders approach. Maybe the radiation, especially brachytherapy techniques, wasn't always perfect at sterilizing the central tumor completely.
Okay.
But today, with modern 3D image-guided brachytherapy, especially a high dose rate, we can deliver incredibly high conformal doses right to the tumor in the high-risk volume. We're talking doses like 85 to 90 gray equivalent.
Much higher central dose than EBRT alone can achieve safely.
Exactly. We can achieve such excellent local control non-surgically that the morbidity, the side effects, the recovery time of adding a hysterectomy just isn't justified anymore. It doesn't improve outcomes further and adds significant risk.
So the modern standard derived from this era is definitive chemo-RT plus brachytherapy. No planned surgery.
Correct. That's the message for residents. Definitive chemo-RT plus brachytherapy is the curative standard. The surgery in GOG 123 was historical context.
Okay, GOG 123 nails it for bulky early stage. What about the more advanced stages, like our Mrs. Davis?
That's where RTOG 9001 comes in. This trial really quantified the magnitude of the benefit for higher-risk patients.
And what was the comparison in 9001?
It directly compared the old standard, EFRT alone, that extended field radiation we talked about, versus pelvic radiation therapy combined with concurrent chemotherapy.
Which chemo regimen did they use in 9001?
They used a combination, 5-fluorouracil or 5-FU plus cisplatin, given concurrently with pelvic RT.
And who are the patients in this trial?
These were the high-risk patients, stage 2B up to 4A, or patients with bulky earlier stage tumors, stage 1B or 2A, but 5 centimeters or larger. And importantly, any stage if they had positive pelvic lymph nodes.
So exactly the group Mrs. Davis falls into with her stage 3C1R.
Precisely. She would have been eligible for this trial.
And the results? You said they were revolutionary.
Absolutely revolutionary. We need to lock in these numbers. Looking at the long-term data, the 8-year overall survival.
Okay.
For the chemo-RT arm, it was 67%.
67%.
Right?
And for the EFRT alone arm?
Only 41%.
Wow. 67 versus 41? That's a 26% absolute difference in survival at 8 years. That's just huge.
It's colossal. You rarely see improvements that large from a single trial-changing practice. And it wasn't just survival. The chemo-RT arm had a 51% relative reduction in the risk of recurrence.
51% lower risk of the cancer coming back.
Right. And here's something interesting about how it worked. The chemo-RT didn't just improve pelvic control. It also significantly reduced the rate of distant metastasis.
Ah, that's fascinating. So the chemo wasn't just acting locally as a radiosensitizer, it was having a systemic effect too.
That's exactly what the data strongly suggest. Cisplatin is known to make cancer cells more sensitive to radiation damage. That's the radiosensitization. But the fact that it also cut down distant failures implies it was likely cleaning up microscopic disease, circulating tumor cells, stuff that had already escaped the pelvis.
So a double whammy. Better local kill from the radiation plus a systemic effect from the chemo.
That's the idea, and that combination is why the results were so much better than radiation alone, even extended field radiation.
So RTOG 9001 basically sealed the deal. Pelvic chemo-RT with mandatory brachytherapy became the undeniable standard, kicking EFRT alone to the curb for these patients.
Undeniably, it completely changed the landscape.
Okay, so we have GOG 123 for bulky early stage, RTOG 9001 for high-risk advanced stage. How is this all consolidated? Was there like a meta-analysis?
Yes, exactly. To make sure this benefit held up across the board, the Cochrane collaboration did a meta-analysis, published around 2010, I believe. They pooled the data from all the key randomized trials, including GOG 123, RTOG 9001, and others.
And what was the bottom line from pooling all that data?
It confirmed a very consistent benefit. Adding concurrent chemotherapy to radiation provided about a 6% absolute improvement in 5-year overall survival across all the stages studied.
6% absolute gain overall. Maybe it doesn't sound as dramatic as the RTOG 9001 numbers in isolation, but consistent and statistically significant across thousands of patients.
Precisely. It cemented the fact that concurrent chemo is mandatory for curative intent in locally advanced disease. That 6% means more women cured.
Okay, let's pivot back to Mrs. Davis, FIGO stage 3C1R. We know her standard treatment is definitive concurrent chemoradiation. Let's get practical. How do we actually do it, and what do we need to watch out for?
Right. So the backbone is the radiation. Pelvic external beam radiation, usually 45 gray in 25 fractions over 5 weeks. This covers the cervix, uterus, parametria, upper vagina, and crucially, the pelvic lymph node basins.
Standard pelvic field, followed by
The mandatory brachytherapy boost, that high-dose rate targeted boost to the cervix and residual tumor.
and concurrently with the external beam, she gets chemo. Now, RTOG 9001U used 5FU and cisplatin, but you mentioned GOG 1203 used weekly cisplatin alone. What's the standard today?
Good question. While 9001 used the combination, the field has largely moved towards weekly cisplatin, typically at 40 milligrams per meter squared, given once a week during the external beam radiation, usually for 5 or 6 cycles.
Why the shift away from the 5U cisplatin combo? Was it less effective?
Not necessarily less effective, but definitely more toxic. Subsequent studies and analyses show that weekly cisplatin alone provided very similar efficacy, similar survival outcomes, but with a significantly better acute toxicity profile.
How so? What was bad about the 5FU?
5FU can be really tough on the GI tract. It causes more severe nausea, vomiting, diarrhea, and sometimes painful mouth sores, stomatitis. This often led to patients needing treatment breaks from both chemo and radiation, which, as we'll discuss, is something we desperately want to avoid.
So the single-agent weekly cisplatin is just easier for patients to tolerate, meaning they're more likely to complete the full course of radiation on time.
Exactly. Better tolerance, fewer treatment interruptions, better chance of delivering the full planned dose within the optimal time frame. That's why it's the preferred regimen in most guidelines now.
Makes sense.
Yeah.
Okay, so we're giving weekly cisplatin. We have to counsel Mrs. Davis about side effects. Adding chemo definitely increases acute toxicity compared to radiation alone. What are the key things residents need to monitor very closely?
This is absolutely critical for day-to-day management. You need weekly labs, non-negotiable, before each dose of cisplatin.
What labs specifically?
3 main things. First, a complete blood count, a CBC. We're looking for hematologic toxicities, specifically neutropenia, low white blood cell counts, and anemia. These are common.
Okay, CBC.
Second, a comprehensive metabolic panel, or CMP. Here, we're focusing on kidney function checking the creatinine because cisplatin can be nephrotoxic.
Right, kidney damage risk.
And critically on the CMP, we're watching electrolytes, especially magnesium and potassium. Cisplatin causes the kidneys to waste these minerals. Hypomagnesemia and hypokalemia are very common and need proactive management.
Magnesium wasting. How big a deal is that, and how do you manage it?
It's a very big deal because low magnesium causes fatigue, muscle cramps, weakness, and can even contribute to nausea and potentially delay chemo. Many patients will need magnesium supplementation. Often, oral magnesium isn't enough, and they'll need IV magnesium replacement, sometimes weekly.
Okay, so check mag levels weekly and replace aggressively, often IV. What level are you aiming for?
Generally, we try to keep the magnesium level above, say, 1.8 milligrams per deciliter, maybe even 2. If it's low, you replace it. If it's severely low, or if the patient is dehydrated or their kidney function is worsening, you absolutely must hold the cisplatin dose, give IV fluids, replace the electrolytes, and then reassess before giving chemo.
So hydration is key too.
Absolutely. Good hydration helps protect the kidneys.
And the third thing to monitor weekly, besides CBC and CMP.
Well, the third isn't a lab, it's clinical assessment. How is the patient doing? Nausea, vomiting, diarrhea. We need to be aggressive with supportive care.
Right. How do you manage the GI toxicity?
Prophylaxis is key. Start antiemetics routinely, often a 5-HT3 antagonist like ondansetron, maybe even add another agent if needed. For diarrhea, instruct patients to start loperamide right away at the first loose stool. Don't wait for it to get bad.
Proactive management. What about dose holding? When do you have to hold the cisplatin for toxicity?
The main reason to hold is significant hematologic toxicity. Specifically, if the absolute neutrophil count, the ANC, drops below 1,000 or especially below 500, that's grade 3 or 4 neutropenia, you must hold the cisplatin until the counts recover. You don't want to risk neutropenic fever.
Okay, hold for ANC less than 500, 1,000. What about renal function?
Yeah, if the creatinine starts climbing significantly, say over 1.5 times baseline, or if there are signs of acute kidney injury, you need to hold, hydrate, and reassess. Protecting kidney function is paramount.
Got it. So careful monitoring, proactive supportive care, and clear thresholds for holding chemo. Now, let's fast forward. Mrs. Davis successfully completes her ChemoRT and brachytherapy. Post-treatment to PET scan looks great, complete response. What's the next conversation? Does she need more chemo? Like adjuvant chemo?
The adjuvant question. This was a really important clinical question for a long time. We achieved great local control with ChemoRT and brachy, but patients still recurred, often distantly. So the logical idea was maybe adding more systemic chemo after the radiation would mock up any remaining microscopic disease.
Makes sense intuitively. Was this tested rigorously?
Yes. This question was definitively answered by a major international trial called the OUTBACK.
OUTBK. What did it compare?
It took patients just like Mrs. Davis, locally advanced cervical cancer, treated with standard definitive chemo-RT who had a good response. They randomized them into two groups.
Okay. Group 1.
Group 1 was observation, just standard follow-up after finishing chemo-RT.
And Group 2?
Group 2 got 4 cycles of additional adjuvant chemotherapy using carboplatin and paclitaxel. These are very active systemic drugs for cervical cancer, often used in the metastatic setting. The hope was this would boost cure rates.
So standard chemo-RT versus standard chemo-RT plus 4 cycles of carbotaxel.
Yeah.
What did OUTBT find? Did the extra chemo help?
The result was crystal clear and maybe a bit surprising to some. It was definitively negative.
Negative, meaning no benefit.
No benefit whatsoever. Adding the 4 cycles of adjuvant carboplatin and paclitaxel did not improve overall survival. It did not improve progression-free survival compared to observation alone.
Wow. So all that extra chemo for nothing.
Exactly. The 5-year overall survival was virtually identical in both arms, around 72%. But the adjuvant chemo arm, obviously, experienced significantly more toxicity.
What kind of toxicity?
The usual suspects with carbotaxel, more myelosuppression, so low blood counts, more neuropathy, that numbness and tingling, more fatigue, hair loss, all for 0 survival gain.
So the clinical takeaway from OTBSAK is?
A takeaway is strong and unambiguous. Routine adjuvant chemotherapy is not indicated after definitive concurrent chemoradiation and brachytherapy for locally advanced cervical cancer. Mrs. Davis can be confidently told she doesn't need extra chemo. OUTBSAK clearly defined the endpoint of our curative therapy.
That's incredibly important data for counseling patients and avoiding unnecessary toxicity.
Right.
Okay, we know the regimen, the evidence, the monitoring, and when to stop. Let's talk about a critical aspect of delivery. The timing.
Yes, the time constraint. This is non-negotiable. We established that brachytherapy is a mandatory part of the cure. But the overarching principle that governs the success of the entire package, EBRT plus brachy, is the overall treatment time.
How long do we have?
The widely accepted standard, based on strong data, is that the entire course of radiation, from the first day of external beam to the last brachytherapy fraction, must be completed in less than or equal to 56 days, 8 weeks.
56 days. Why is that number so critical? What happens if treatment drags on longer?
It comes down to tumor biology specifically, accelerated repopulation. During a course of radiation, especially a protracted one, the cancer cells that survive the initial radiation fractions don't just sit there, they can start to divide and repopulate more rapidly.
Trying to grow back during the treatment itself?
Exactly. The radiation kills cells, but if you take too long, the surviving cells kick into overdrive. If you delay that final high-dose brachytherapy punch for too long, you lose the race. The tumor starts to outgrow the effects of the radiation.
And the data supports this. Longer treatment time equals worse outcomes.
Absolutely. Seminal work by Perez, Peter Wright, and others clearly showed that for every week, the overall treatment time extends beyond that 8-week, 56-day window. The probability of local control drops significantly, maybe by 1 or 2% per week of delay.
That sounds small, but over several weeks, it could be the difference between cure and recurrence.
It absolutely is. A few % drop in local control translates directly into worse survival. It's catastrophic for curative intent. This isn't just a scheduling guideline, it's a biological imperative.
So this time as tissue concept is paramount. Let's try an analogy for the residents. If EBR is like, say, clearing the forest.
Yeah, EBRT is like clearing 90% of the forest. It gets rid of the bulk. But the remaining 10% are the toughest, most resistant trees, maybe hiding in valleys. Brachytherapy is the targeted, high-intensity strike, maybe like a controlled burn or a specific removal, designed to get that resistant 10%. If you wait too long between the initial clearing and that targeted strike, those tough trees start to regrow aggressively. The 56-day mark is essentially the point where that regrowth starts to overwhelm your ability to eradicate it completely with the planned dose.
So the urgency is real. How does this impact planning?
It means you have to be thinking about and planning for brachytherapy early. You should be scheduling the brachy consult and simulation around week 4 or 5 of external beam, aiming to start the brachy boost the week immediately following EBRT completion, or sometimes even integrating it during the last week of EBRT if feasible, to ensure you finish everything well within that 56-day window.
What about those inevitable delays? What if Mrs. Davis gets grade 4 neutropenia from the cisplatin and needs a week off? Or she gets really dehydrated? What takes priority, sticking to the 56-day radiation schedule or getting all the chemo in?
That's probably the toughest clinical judgment call we face sometimes. Generally, if a patient has severe toxicity requiring a treatment break, the consensus prioritizes minimizing the interruption to the radiation schedule.
So you might hold the chemo, but continue the radiation if possible.
Often, yes. The primary driver of local control is the total radiation dose delivered within that optimal time frame. While concurrent chemo is crucial for radiosensitization and systemic control, a prolonged break in radiation significantly jeopardizes the chance of cure. So, if forced to choose, you might hold a cycle of cisplatin to allow the patient to recover enough to continue radiation, aiming to complete the RT course within or as close as possible to 56 days.
Even if it means they don't get the full planned chemo dose.
It's a balance, but yes, preserving the radiation timeline to maintain local control is often paramount. Obviously, you try your best to manage toxicities proactively to avoid these breaks altogether, but delays happen, machine breakdowns, patient illness, scheduling conflicts. The resident's role is constant vigilance on that calendar and aggressive toxicity management to keep things on track.
Okay, that's a critical practical point. Let's consolidate all this with some board-style review cases. Ready?
Let's do it.
All right, case number 1. You have a 60-year-old woman diagnosed with FIGO stage 2B cervical cancer. She's referred for treatment. Which of the following is the evidence-based standard of care? A, EFRT alone to 50.4 gray. B, pelvic RT followed by 6 cycles of adjuvant chemotherapy. C, concurrent pelvic chemoradiation followed by a brachytherapy boost. Or D, primary radical hysterectomy followed by adjuvant chemoradiation.
Okay, stage 2B, parametrial involvement but not to the sidewall. The standard's definitely C. Concurrent pelvic chemoradiation followed by a brachytherapy boost.
And why C? Based on which evidence?
Based primarily on RTOG 9001 and the subsequent NCI alert. Stage 2B is locally advanced disease. Radiation alone, like A, is inferior. Adjuvant chemo after RT alone, like B, isn't the standard upfront approach. Primary surgery, like D, is generally contraindicated for stage 2B due to the high likelihood of needing post-op RT anyway, and chemo-RT offers excellent cure rates non-surgically. So C is the established evidence-based standard.
Perfect. Case number 2. A 45-year-old woman. She has a 4.5 centimeter node-negative stage 1B3 cervical cancer. She's treated with preoperative chemoradiation, followed by a hysterectomy. This specific historical approach, using chemo-RT before surgery for bulky early stage, is most directly supported by which landmark trial? A, the Landoni trial. B, GOG 123. C, RQOG 9001. Or D, the LACC trial.
Preoperative chemo-RT for bulky stage 1B. That points directly to B, GOG 123.
Explain the connection.
GOG 123 specifically looked at bulky stage 1B tumors defined as 4 centimeters or larger. Her 4.5 centimeter tumor fits perfectly. The trial compared RQ plus surgery versus chemo-RT plus surgery. It showed a clear survival benefit for adding the concurrent cisplatin in that setting, demonstrating that chemo-RT improves outcomes even when surgery is part of the plan for these bulky early tumors. We don't routinely do the surgery anymore. GOG 123 provides the level 1 evidence for adding chemo to RT for this specific bulky stage 1B scenario.
Excellent reasoning. Okay, final case. A 58-year-old woman completes definitive chemoradiation and brachytherapy for stage 3B cervical cancer. Her post-treatment PET scan shows a complete response. She's feeling well, but asks her doctor, shouldn't I get some extra chemo just to be safe? What is the most appropriate counsel? A, Yes, 4 cycles of adjuvant chemo will further reduce recurrence risk. B. No, adjuvant chemo is not recommended as ODB-PA6 showed it adds toxicity without improving survival. C. Yes, adjuvant chemo is recommended, but only if she has adenocarcinoma histology. Or D. No, because her disease was stage 3B, she's not a candidate for more chemo.
The clear evidence-based answer here is B. No, adjuvant chemotherapy is not recommended because the O2B-P8 trial showed it adds toxicity without improving survival.
And that applies regardless of stage, right?
Correct. OGPPs included patients with stage 1B1 with positive nodes up to stage 4A. It showed no benefit for adjuvant carbotaxol across the board after complete response to definitive chemo-RT. So you counsel her based directly on that high-level evidence. The risks of extra chemo outweigh any potential unproven benefit.
Fantastic. Okay, let's crystallize this. 3 high-yield clinical pearls that every resident should take away from this discussion. Pearl number 1.
Pearl 1. The 1999 NCI clinical alert was the watershed moment. It mandated cisplatin-based concurrent chemo-RT as the standard for locally advanced cervical cancer based on multiple trials, ending the era of RT alone.
Pearl number 2.
Pearl 2. Remember the magnitude of benefit shown in RTUG 9001? That massive 8-year overall survival jump, 67% since 41% compared to EFRT alone, proves the power of adding concurrent chemo for high-risk patients, reducing both local and distant failures.
And pearl number 3.
Pearl 3. Time is tissue. The 56-day rule is absolute. Finishing the entire radiation course, including brachytherapy, within 8 weeks is critical for maximizing local control. Any delay increases the risk of treatment failure due to tumor repopulation.
Excellent summary points. So quickly recap our whole discussion.
We've established that for locally advanced cervical cancer, like Mrs. Davis's stage 3 C1R, concurrent chemoradiation is the undisputed standard of care.
Right. We saw the evidence build, starting with GOG 123, showing benefit even in bulky early-stage disease.
Then RTUG 9001 demonstrating that huge survival advantage for higher risk and node-positive patients.
Consolidated by the Cochrane meta-analysis, showing that consistent 6% absolute survival benefit across the board.
And finally, the OUT-BASIC trial defining the end of curative therapy, confirming no role for routine adjuvant chemotherapy after successful chemo-RT and brachytherapy.
This entire evidence base really dictates our modern management. Knowing these trials, their results, and their implications is just fundamental.
Absolutely fundamental for providing curative care.
Okay, so we've nailed down the what and the why. We know the evidence for concurrent chemo-RT.
Now we need to talk about the how.
Exactly. Our next session is going to be an EBRT planning workshop. We'll get into the nitty-gritty technical details.
Yeah, we'll cover target delineation, how you actually contour the tumor, the nodes, the organs at risk. We'll discuss some key mnemonics, especially for ensuring adequate pelvic nodal coverage. And critically, we'll go over the dose constraints you need to respect to minimize long-term toxicity to bowel, bladder, rectum, while still delivering that curative dose.
It's going to be very practical, very hands-on. To really test your understanding of today's material and prepare for those high-stakes scenarios, make sure you complete practice oral boards over at radonsmartlearn.com.
That's radoncSmartLearn.com.
And definitely subscribe to Rad on Smart Review so you don't miss that upcoming EBRT planning workshop. Thanks so much for tuning in today.